I'm going to go ahead and record it on my computer unless you already started, Shane. Did you?
I just started, but if you want to record it.
Yeah. Oh, Sean, that's great. I just didn't know if we could rely on it with the little hiccup earlier, but that's great if you've got it.
Yep.
Okay, so hello everyone, and I just want to check, phone number 360-878-0129, is that somebody's phone number in here? Can you guys unmute yourselves or raise your hand if that's you?
That's Sue Birch. I have
thank you.
Video and phone connection.
Okay, that's great. I just wasn't sure, so thank you. Okay, so everybody, thanks again for your patience and flexibility today. So our first question really is, what are your key takeaways from the presentation that Janine just sort of did a quick overview of, and the pre-recorded presentation about the work ahead to implement a universal healthcare programs? Just go ahead and raise your hand, and you might be able to unmute yourselves. We're a small enough group that it's probably okay. So what are your initial reactions or key takeaways from the presentation today and the pre-record on the work ahead? And I know we heard a little bit about it earlier, so go ahead.
Oh, this is Sarah Weinberg. This brings back memories. In 1998 to 2000, we're talking about 20 years ago and counting, I was very much involved in the writing of the Washington Health Security Trust, which has been a bill now in the legislature for over 10 years. A lot of these problems are addressed in that bill. And it would be a good idea for us to be looking at that bill for some of the answers to how to administer a single payer system, how to go about applying for help from the federal government in terms of getting their money in, which we absolutely would have to have in order to do it, as well as enrolling their populations like the Medicare population and the like. And how to set up groups of advisory committees to handle quality, handle public concerns, and handle new therapies and drugs and things that come along, what should be added to the benefit package, et cetera, et cetera. A lot of this work has already been done. We need to take a look at that. We do not need to totally reinvent the wheel.
Can I ask a question about that?
Go ahead. Oh, Shane, go ahead.
So presumably in the bill, it talks about the strategies that would be employed, but what would it mean to actually try and implement all of those committees? Because the committees themselves aren't established. The actual work that would have to be done hasn't been done, but the roadmap for how you do it has. In terms of timelines, like when we're talking about a 2022 implementation, just using your historical context, you seem to have a grasp on what some of the steps that would need to happen. What is a realistic timeline given all of the things that are in those historical bills for the committees that need to be set up, the stakeholder engagement processes, the federal authority?
I believe the WHIST intended, the Washington Health Security Trust gets nicknamed the WHIST. I believe it intended to be implemented over a couple of years, and it started collecting money from it was funded with a payroll tax and with an individual premium, and the money was to come in for a smaller amount from the payroll tax in advance to build up a reserve fund so that it had the money to roll out a year and a half or so after implementation. But if it had been implemented, then committees could be set up for, the three were financial, citizens advisory, and technical advisory. Those could be set up right away to start to deal deal with issues like defining the benefit package and other issues like that.
Sherry, I just want to ask a clarifying question, and then I know Shane has another question as well. So it sounds like what you're saying is that this is it's drafted legislation that actually lays out a financing mechanism for implementation efforts, not for funding the actual program. Is that what you're saying?
Actually, it did lay out money for the whole thing. Then the initial drafted thing in 2000, which we tried to run as an initiative, failed to get enough signatures. That's a whole nother story. And lately, since every time it was in the legislature, they promptly attacked the financing. Nobody wants a payroll tax. Nobody wants, even if you call it a assessment instead of a tax, nobody ever, people don't want to do that. So they would focus on that and not on what it would do. So the most recent version sets up a legislative committee charged with finding the financing. All right, where are you going to get the money for this? And then so that would be part of the bill. But the intention was to raise enough money to actually pay for health care for all Washington residents eventually.
Okay. So Shane, go ahead.
Sue, do you mind if I pick on you just a little bit? Well, maybe this can be a broader question as well. So I worked for close to 10 years in the Colorado Medicaid agency, and we went through Medicaid expansion, and we went through a major expansion of delivery system reforms, and just thinking about all of the steps that are needed to get to a safe implementation where people that are vulnerable are not put at risk. There's all of these different categories of bodies of work that have to be done, from stakeholder engagement. And I mean, like in this case, we're talking about a really broad stakeholder group from ERISA plans and unions that benefit from special negotiations on healthcare benefits that lose power under this. There's really complicated dynamics. Part of what we're trying to think through is like all of these major bodies of work that the state would have to resource prior to implementation that should be a consideration for the cost to go into that. And I could probably name, like 50, just running through the list of developing a claims processing system and provider contracting and putting out an RFP to get contracted entities to do 20 different bodies of work. In order, I think one of the things that we see is that there's all of these studies and all of this great intent, and they all, I think that people recognize that on the star on the horizon is more efficient and better for people, and why shouldn't we chase it? But one of the things that I don't see in the reports is a really robust evaluation of what it takes to get there. And I think one of the greatest value adds that we could contribute to this conversation, short of actually implementing universal healthcare, is to really map out what it takes. And I think that's what we're looking for, is like, what are those really big bodies of work that you have to sink your teeth into, and it's hard work, and you have to resource that work in advance. Like what are those things from your perspective, in addition to some of the great foundational work that you've already put out there that you mentioned has been worked on through the legislative process?
Actually, the WIST, as I remember, initially allocated something like $50 million for setting the whole thing up for initial implementation expenses. Now that's 20 years ago. It might cost more now. And of course, the other thing that was really different 20 years ago is the amount of consolidation of hospitals and other providers that become a giant behemoth that is into profit, and trying to take them on is not going to be simple. It wasn't going to be simple then, and it's much worse now.
So I just want to go back to, I think Shane, Sue, it would be great if you, as a state agency, director of a state agency now, and also someone who was involved in implementing the ACA at a state level, like what is that? I think Shane was trying to sort of cue up the question about like, what is your reaction or what are your thoughts about this kind of work? And like what kind of lift is involved? Okay, sounds like maybe Sue is dealing with something else. So let's go back to our original question, and thank you, Sherry. So what are some other folks' responses to the presentation that Nora shared in the pre-record and also what Janine talked about today? Just kind of any initial reaction. Oh, go ahead. I hear somebody.
This is
There's
Sue. I'm sorry, I had to double unmute.
Oh, sure.
So, you know, the comment and the question about, so what would it take to implement? I mean, we currently work with our employee retirement benefits with PEB and SEB, which is our public employees and our school employees, in a structure with a third-party administrator, Cambria Regents. And so we would just scale, but I think what's unprecedented here is all the federal approvals. And I also think that we have typically worked with more certainty with models. And so I think those would make this lift extraordinarily more complex. And I think the federal negotiations and discussions really just depended on whether it was a supportive administration or not. So those were just my initial comments as I've listened carefully today.
That's great. I really appreciate the comments about SEB and PEB and, you know, thinking about how you could potentially scale those up, because I think Jane was touching on that earlier when she said, you know, there's a big gap between option A and option B, and what about administering it like that? So thank you for that comment. Other folks, Patrick, I don't know if you stepped away for a minute. I'd love to get any of your insights or any reactions or takeaways from the presentation about feasibility and administration.
Well, thanks, Liz. I think at a minimum, and for the sake of the limited time we have today, we should include those same kinds of identified obstacles that Oregon included. I suspect that those are probably quite similar to some of the impediments that Vermont had. You know, several states have taken a look at how do they try and approach a universal healthcare system of some sort, and none have succeeded. So, you know, perhaps there is a way for us to find a different approach to those same problems, but those same problems are still going to need to be resolved. I mean, we've seen in the briefing materials repeatedly about the likelihood of success or lack of likelihood of success for trying to overturn or get some kind of exemption to ERISA. We haven't touched much on Taft-Hartley, but that would be a similar type of issue. I thought it was interesting that in the presentation that Shane did earlier, talked about including Medicaid in this kind of approach, but not Medicare. Once again, I think that federal burden is still one that has to be overcome, and I'm not sure that there's a clear path forward for doing that. So in terms of putting together the matrix that you showed at the outset, again, I think at least we need to include those same kinds of concerns that were identified by RAND in the somewhat recent Oregon report.
Sure, thank you. Carrie or Sybil or Ronnie, any comments or reactions to, you know, the presentation, the brief, you know, review and the pre-recorded presentation?
So
go ahead, Ron.
So I would say that from my perspective, looking just at specific drug-related issues over the years, that Washington State has so many of the implementation parameters in line already. There certainly are Medicaid evaluation programs that I've seen and seen the results of in my practice that the healthcare authority is already doing. Certainly there will be expense, as I think Sue was just referring to, of increasing that, expanding that. There's no doubt that there'll be implementation costs, but I think two things. One is that Washington State is in a really good position because of some very powerful work that's been done by our healthcare authority, by our insurance commissioner, to pull together some of the data management issues. I think that we've got a step ahead. And the second thing is that we're not the only state that's doing this. We certainly can depend on the work that other states are doing to implement programs like ours. I remember being a part of a multi-state pharmacy purchasing organization where Minnesota was the state that actually did the data management, but all states were involved. Washington State did something else as a part of that coalition, but so I think that we have that support. Shane talked about what Colorado has done, and certainly we would have access to that. And so I don't think we're alone, and I think that we have a very powerful healthcare authority and insurance commissioner office and infrastructure in Washington State that gives us a very powerful step forward in this.
Thank you. Great. Carrie, Sybil?
I think I would add, I mean, we're going to get into the details the further we go along, and you know, the transactions and the minute kind of things, and I think we always have to remember that for the public, we need to understand what you're trying to accomplish. We need to understand the big picture, and we need trust. So the more we trust you, the more we don't have to know all the nitty-gritty details, because we know that you understand what we want. Speaking as a public person, that if the more I trust you, the more you know you have the support to change some of these blockers and to do that. So, you know, when we present things like, you know, we're going to have cost savings, but the cost is going to go up. You know, you have to put that in bite size so the public can understand it and go, yeah, okay, let's do something about ERISA. Let's do something about that, because I want what the vision of what you guys have, or where this is going. Because we talk a lot about cost, which is what we are doing right now, but we always need to put it in terms of the benefits you're going to get if you make this investment. And I would strongly start us already putting our presentations into, if you make this investment, this is what you're going to get. And the more we can do that, the more people won't take those sound bites and run with it before we have a chance to put the whole plan together.
Okay, great, thank you. And Sybil?
So I agree there are a lot of administrative challenges, but I'm curious and excited about thinking about how to approach them over time and build something up over time. I don't think that we would have capacity to do, I mean, clearly as we learned, wouldn't have capacity to do something in an instant, but I'm curious about what is a program of expanding coverage over time to get toward universal healthcare. I do agree that there will be, for unions, people have worked really hard to bargain health benefits and have fought like years and decades to get them to where they are, and made a lot of compromises on wages and other things to be able to get health benefits. So I do think that there is concern about maintaining what people have, but I'm curious also about opportunity to use a universal coverage plan as a baseline and then build upon that with union plans or other opportunities for healthcare that people have. So yeah, I think there are definitely challenges, but it raises questions for me about how to move forward in a good way, in a positive way.
Yeah, in a positive way. So I think, you know, going to our next key question, and I think Sybil, to some extent, I don't know, I've said this before with our work group in general, you know, is there a pathway that goes to one model and then goes to another model? I think we've talked about that before, like, do you go to B first and then A? knowing that it's going to take longer to get there? What are those kinds of things? So I guess my question for all of you is actually, what have you learned about the feasibility of the 3 different models, and what is that, has that influenced your thinking at all? Oh, we have 10 minutes left for this question. So.
The thing that I've learned from all of this is that it is much more important that we set the ultimate goal especially when we approach the public, that we have a plan that is going to get to covering everybody in the state of Washington, everybody in, nobody out. It's going to take time because of all these various hurdles, but our plan is to get there. So I don't want to say, well, we'll start with C, and then if that doesn't work, we'll try B, and then if that doesn't work, we'll try A. That isn't a plan to get to universal coverage. And I also think that it's so important that we make it crystal clear to the public that healthcare is something everybody should have as a citizen or as a resident of Washington State. It is not a product to be sold by vendors and bought by consumers. It is something to be there for people when they need it, when they are patients. And I think we must make that the central theme of what we come up with. Then we can talk about, all right, here are the difficulties in getting it done, and we have this step and that step. We can start by covering everybody who already doesn't have other kinds of insurance, and then we can fold people in over time. And it's going to cost money, and we need people who will figure out how much it costs. Then we can figure out how we're going to raise those costs. Most people don't even know where their insurance comes from. It comes out of your paycheck and you don't even see it. So what you see is the cost sharing. Anyway,
okay. Well, so, and I think that, we're looking at these different models. They're just administrated differently. And so I guess for others, I'm curious about, and we started to have that discussion in our large group when Jane and Dr. Tritko, I think, brought up comments about having the kind of big wiggle room between option A and option B around how the program is administered. What is your all's reaction to that? And I would really love to hear from some other work group members. I'm not going to call on you again like school. Go ahead. I think Ronnie's unmuted. I would love to hear from you. Are you frozen? Okay, here you go.
Yeah, I'm not sure what you're asking me.
Oh, just I'm asking in general, what have you learned about the relative feasibility of the 3 different models, and how has, if that has influenced any of your thinking about a recommended model?
Well, I think there certainly are a lot of that the support staff have really helped identify a lot of the issues, and that there are certainly costs for implementing, for data management or quality assurance, and negotiating networks. There are certainly costs that are evident in that. And there are also, you all have pointed out the needs for making the statutory changes that are necessary and making the decision. I think that's a big part of what we have to face and push for. So I think there's several levels of issues that have been made really clear, and that there is a lot of work, not just costs of implementing it through our state government offices, but the actual costs to our time to make those changes and convince the public and make the regulatory changes to convince the legislature.
Carrie, go ahead.
Yeah, I think that's where what I was listening throughout this is, there's quite a lot of reliance on removing the ERISA restrictions. And, I worked at Microsoft. I know several people at Microsoft, and I don't know how they're going to give up their insurance unless you have a conversation with them around you're going to, around their expectations, because they're not going to willingly do it just because we want to cover everyone. I think we need to just be realistic. There are people that disagree that covering everyone is the goal of universal health care. So I think we need to speak to people's perspective directly. And some people love the global and they want everyone covered. Well, we also have to talk to the people that don't have that as a goal of universal health care. But they would be interested in universal health care for their specific reason. What are those reasons? How can we talk to that? Because if we just throw this out there and go, we need to convince you. I think we've already learned we can't convince anybody anything once they've made up their mind. And most people make up their mind before you get a chance to talk to them. So it's or in the first 30 seconds. So I think we need to think about that a lot. And the one thing if these models are based upon ERISA and they only work if ERISA, or if all the self-insured employers in Washington state are agreeable. I mean, you really would need Microsoft to come out and say, we think this is a good plan to move through and we support it. Otherwise, you're never going to get the employees on board because it's just one of the best self-insured healthcare plans out there.
And Liz, back
Go ahead, Patrick.
to your more global question. Through the course of this, I think first, one of the challenges I have is that I'm not convinced we have an agreement on what our objective is here. Is it universal coverage? Is it universal health care? Is it a single payer system? We've got these three models that seem to have come together sort of like prepackaged, perhaps somewhat based on some conversations in some of the breakout groups that we've had over the course of the last 5 or so meetings. But I don't know that the work group itself has come to a meeting of the minds as to what the goal is here. And in terms of feasibility, I'm not convinced at all that option A or even option B are feasible or that they could be accomplished in a reasonable period of time. I'm just not sure that with either party in power in Washington, D.C., you get the kind of federal changes that you need in order to authorize us to move forward in a meaningful way. Carrie hit the nail on the head. There are a lot of workers, as Sybil mentioned also, a lot of workers, a lot of employers who have spent many years developing a healthcare benefit plan that works for them. They're not going to jettison that easily. Moreover, I would say that I personally am somewhat concerned about what the future state of healthcare in this state would look like under some type of a quote unquote universal healthcare structure. I mean, is it going to look like the workers' comp system? I don't think that's a step forward for us. Is it going to look like the VA? I don't think that's a step forward. Is it going to look like Medicaid? Again, not a step forward. One might argue Medicare or try and put that into the Plan B box. Maybe that works better for some, but keep in mind with Medicare, there are other wraparound policies that are out there. So it's not a silver bullet either. So I think until we decide what it is we want the system to look like, what we want it to cover, who's in, who's out, we have a whole lot more to discuss before we get to some kind of actionable plan about adopting some sort of a universal coverage, a universal healthcare type of system that would work in Washington state.
I think you raised some really good points, Patrick. And Carrie as well. In terms of what the models assume, you can remove populations or add populations. You can make it comprehensive such that everyone has it, whether they have Medicare in addition to it or not, or have it subsume Medicare, like in which case it'd be secondary and it picks up all of the additional costs. We've modeled that. It costs an extra $1.2 billion, chump change, right? but to your point of what is the end state goal, hopefully these discussions have provided the context around like what some of the cost implications are of these decisions, to where we can get to a concrete, yes, well, we have a better understanding about feasibility and some of the cost aspects. This is what we want to achieve, and how do we need to modify those assumptions accordingly. I would also note, I do feel like we're hearing pretty loud and clear. I mean, maybe it's a problem of the loudest voices, which can happen, but noted. There, you know, the concept of comprehensive for everyone covered has been a strong theme that we've been picking up. Again, acknowledging it could be a problem of the loudest voices, we hear the loudest. But you know, it's a great point. I think we should take this as part of the feedback to the broader group of, you know, there isn't broad consensus on what the end state is, and we need to get to a consensus for the recommendation report. And the implications of that, of those decisions, are actually pretty significant in terms of what you would have to do both federally and in terms of stakeholder input and buy-in from employers, for example. So I hear you loud and clear.
Sybil, we have like 20 seconds left. Do you have anything you want to add about how these presentations have influenced your thinking, or anything you want to know more about?
No, I mean, I think that it's been helpful to understand what all the challenges are, and where we need to focus our attention, that that there are so many steps at the federal level that need to be taken is helpful to hear. So yeah, I think I still want to think more about it, but I found it helpful. Yeah, and I would say, in addition to my comment about the wonderful healthcare plans that many of our union members have been able to bargain, there are also many union members who feel challenged by healthcare being tied to their health, to their employer. So in our labor movement, we have a wide variety of perspectives and strong opinions across the board. So yeah, so that's what I would say.
Thank you. We might get whisked away, but Sue, I saw that you unmuted. Do you have any comments?
No, I'm really just actively listening.
Okay, no, that's great. I really appreciate it. And Sybil, I recall your comment from before too about having one sort of base thing, and then people can kind of level up with their own coverage that they have, and that's really important feedback as well. So I really appreciate everybody chiming in, and I hope it wasn't embarrassing that I called you out by name, but we just want to make sure everybody's voice is heard, so thank you. And we'll probably get whisked back in just a moment, I think. So that's a really cool light fixture behind you, Patrick. I've been looking at that.
Yeah, Amy picked it out, so she gets the credit for it.
Yes. Are there any final comments before we disappear from each other's faces? Go ahead, Ronnie.
So I think that we've certainly identified some barriers in the way, but there are just as many union members and people in the public who want universal coverage and think it's the equity or most fair thing to do. And there are just as many business owners who are saying, I'd rather not deal with all this healthcare problem. What if we took the responsibility off of them? So I think it is a big political issue, social issue that we need to find answers for. And I think we only do that if everyone puts their heads together and comes up with a clear solution.
Great, thank you. Well, you guys probably got the notice that you can leave the breakout room, or it's going to take us away in 8 seconds. So we'll see you back in the big main room.
Thanks, everyone.
Thank you. Okay.